Hi, everyone. Welcome to the Society of Thoracic Surgeons General Thoracic Surgery Database, the monthly webinar. Today is Wednesday, April the 13th. So thanks, everybody, for joining. On the call with me today, let's see, from the STS side, we have a good amount of folks today. We have myself and Carol. We have Addie, Emily. We have Katie from our core group and Ruth from our core group and consultant. And Sydney Clinton from our IQVIA team. Let's see here. We've got Joe, Case, Melanie, Steve, and I think that's everyone. So thanks everybody for joining today. Let's see here for our agenda. Again, I'll just provide a brief STS update. And as Carol stated, I'm going to turn things over to her, and she is going to present on the STS audit, give a recap of the 2021 audit, and provide some important information for the upcoming 22 audit that will be starting here soon. Then we'll turn things over to IQVIA for their update, and as usual, we'll finish up the session with your user feedback. Please submit your questions via the Q&A. If you've submitted a ticket to IQVIA and need feedback, if you could please include that ticket number in the Q&A so the IQVIA team could start to look that information up for you and get you some feedback. So let's go ahead and get started. All right, for our STS updates, again, I really don't have a lot of information since our last call, but the training manual for April will be posted by the end of this week, so that will be coming, so stay tuned. Again, that will be posted and available to you all by the end of this week. And again, just to recap the fall 21 analysis results, that the resection for lung cancer report was released Monday, March the 28th. That the updated analysis overview was posted, and that updated overview does include the information for the resection composite details, and that is available within the IQVIA library. Also, just a reminder that the NIS dataset now reflects 2019 data. The analyses previously utilized the 2015 dataset, but again, we have updated information for NIS, and that is based on the most recent 2019 dataset that is available. GTSD public reporting, just again, a reminder that the next update is scheduled for this spring, so that will be coming soon. The public reporting refresh will utilize results from the fall 2021 harvest, and again, that includes surgical dates of July 1, 2018 up through June 30th of 2021. If you have any questions regarding public reporting, if you could please direct those to Sydney Clinton. Her email is listed here. I believe she's also on the call today, so please feel free to put any of your questions into the Q&A, and we'll get those answered today. Also, the STS database team did want me to remind you all, if you are reaching out or inquiring about IQVIA platform access, if you are needing to add new user accounts or deactivate current users at your site for access of the platform, if you could please contact STSDB at sts.org for assistance. I think many folks have been reaching out to IQVIA directly, but new user accounts and deactivating user accounts must be done by the STS directly. So again, if you have questions or need information on new user accounts or deactivating current users, again, please reach out to us at stsdb at sts.org for a quicker turnaround time. Next slide. I think that's all that I have. Oh, actually, just did also include the harvest schedule. Again, the fall 22 harvest is currently underway. That harvest is scheduled to close September the 9th, and the opt-out date is September the 13th. And again, that will include procedures up through June 30th of 2022. And that's it. So I'm going to turn things over now to Carol, our STS clinical manager for the STS national databases. And Carol, the floor is yours.
Great, thanks, Leanne. I'm going to get started here just one second. I'm trying to put something in the chat box for everybody. We were asked to, like Leanne had just presented on the last slide, we were asked to ask folks to please reach out to the STSDB with updates and contact updates instead of reaching out to IQVIA. But I think the first step that we'll need to direct you to is to use the participant contact form. And then if you have questions with that, to please reach out to STS DB at sts.org, and I'll put that in the chat box.
Thank you.
But the first step, I think, is going to be to use the link that is there. So there you go.
Thanks for
Okay.
clarifying. I appreciate it.
Yeah, I forgot about that when we were talking, and I'm like, oh yeah, they shouldn't be reaching out to IQVIA. They should be reaching out to us, but we actually have a process in place for it already. So the participant contact form, and then if you have questions about who's listed as active on your site or anything like that, you could reach out to STSDB and we could provide you a list of active surgeons and data managers, primary and your backup data contacts. Okay, I'm going to get started here. This is the 2021 audit results and then a 2022 audit update. I'll probably, Ruth, you don't know this yet. Surprise, surprise. I'll probably be saying your name a couple times and asking for your input. So I know we've reviewed these together and it's just kind of a formal presentation for everybody on the call. So in 2021, 26 general thoracic sites were audited. We audited 20 randomly selected medical records. We aimed for a mix of 15 lobectomy and 5 esophagectomy cases. If a site did not have 5 esophagectomy cases, we filled those in with lobectomy cases. Any combination to get to the total of 20. The OR dates that we looked at were July 1st, 2019 through June 30th, 2020. We chose this broken out this way because we did not have an opportunity to perform an audit in 2020 due to COVID and trying to be respectful of all the stress that sites were under during that time. So the audit was performed in 2021. We didn't want to skip over 2019 data. So typically when an audit is performed, we're looking at the year prior. So we would have looked at 2019 if we had performed an audit in 2020. Since we skipped that audit in 2020, our next audit date was 2021. We included half of 2019 and half of 2020 just so we wouldn't skip over 2019. And I'll get to that in I'm going to talk more kind of about the audit dates when we get down to the 2022 audit, because it's going to be a little bit different, not for COVID or anything related outside of the STS, but just the way the version update go live date went live. We audited 54 2.41 data elements for each site. An overall agreement rate is 95.6%, which is really great, and complications agreement rate is 93.9. We're going to talk more about that in a second when I get more granular into the data that the outcomes that we got back from the auditing company, and I'll share a little bit more information about the complication agreement rate with you. It's actually much higher, probably closer to 97, 98%, depending on how you look at it. So I'll go into that in more detail. And then the discharge mortality agreement rate was 99%. This year was the first year that we had a formal audit policy in place. Previously, we had an audit policy in place. It was just really never formalized with approval from the STS board. About how we would be returning results back to sites and a kind of STS's role in helping sites identify where there's issues at and holding sites accountable if they're having a difficult time abstracting accurately. And oftentimes it's not that a site is lazy in their abstraction. It could be turnover or the getting pulled to different areas or having multiple responsibilities. So this year, the surgeon leadership of the STS wanted us to have a formal audit policy in place. The audit policy will, and we'll go over it on the next slide, the audit policy designates sites as either exceeding expectations, meeting expectations, or not meeting expectations. And there's a couple ways that you could not meet expectations. The sites who did not meet expectations, they will be re-audited in 2 years. So we give them a year to kind of recoup and figure out if there's a process issue at their facility, or even just get a little bit further comfortable with the general thoracic database. So those sites will be re-audited in 2023. We had 6 sites exceed expectations, 14 sites meet expectations, and 6 sites who did not meet expectations. Along these 26 sites, we had 2 sites who scored greater than 99%. I think each of these sites, one site had, out of all of the variables that were abstracted, they only had 2 wrong, and one site only had 1 wrong, which gave them like a 99.9% rate of accuracy. This is really great, and they should be commended for all of their hard work in ensuring that the accuracy of the data is maintained for the STS database. So thank you so much for all your hard work. And I know that it's not always easy to get the right data, but you should be very proud of yourselves for your scores. The audit is not punitive. It's not intended to be punitive, although we do have this re-audit in place. The goal of the audit is to help ensure that the accuracy of the STS database maintains its the high integrity that is expected of it. Since this data is used for improving the care of general thoracic surgical patients and esophagectomy patients, we want to ensure that the data we're using to provide quality improvement or quality assessment, not just at a site level, but on a national level, meets the standards that our patients that we're charged with caring for deserve. So that's the kind of the point behind the audit. Re-auditing a site doesn't necessarily mean that the site is a bad site or lazy in any means. It just means they need a little bit of help, and we want to help them get there. So if you are one of these sites who needed to be re-audited, we'll get more into that on the next slide, but just know it's not punitive. We're not looking at it. And we do realize that you have to, your surgeons usually are aware when your site gets audited. We send out emails to the surgeon leader at the surgeon representative at your facility. So oftentimes a lot more people than just you are aware that you're being audited, and they're looking for these results. So even though we don't consider that punitive for the purposes of STS, we do understand and recognize that these results are looked at as could be looked at as your performance as an abstractor. So we really encourage you to reach out because we don't want to be a cause of you having bad discussions at your site with your surgeon leaders or your C-suites regarding audit results. If you're having a struggle or you're having issues with resources at your facility to abstract the data accurately. With all that being said, we're going to go right into the audit policy. This is posted on the STS website, and I'll show you where that's located at. It was formalized prior to this audit. And essentially, I just pulled out the section here that I think is important. We have in blue here. Well, first I want to just say 98% or greater is defined as a site that meet expectations. This is for all sections excluding complications or the mortality. So 98% is greater is a site that exceeds expectations. 90 to 98% is a site that meets expectations, and less than 90 is a site that does not meet expectations. For the mortality or complication section, we expect you to have very good data in these sections. So we expect that our expectations is that 98% of the time you should be getting these fields right, and that is meeting expectations of the STS. 90 to 98% does not meet expectations, and any site who scores less than 90% on these sections will be requiring a re-audit, no matter what your overall section score was. Sites identified as not meeting expectations for overall site accuracy, or sites having less than 90% accuracy on the complications or mortality sections will require a follow-up audit within 2 years. And I know that we said this is not punitive, but we also want to maintain the higher integrity that the STS database is known for. And we want to make sure that decisions are being made for patient care and procedural care for these patients is done using clean and accurate data. So for that reason, any site who does not meet expectations for that second re-audit, they jeopardize their participation in the STS national database. So just as a side note, just be aware of this. If you are one of the sites that need to be re-audited, it's very important that you use all tools that you have possible to clean up data. so that you do not put yourself at risk for not being able to participate in the database. We don't want bad data in the database, and if we're identifying your site as having problem areas, we don't want to make decisions with that data. So please make sure that you clean up your data. And then if you need assistance, please do not hesitate to reach out to Ruth, Leanne, or myself for any questions, if whatever they may be, or if you're having a hard time understanding a specific definition for one of the fields, or procedures that need to be entered. And you'll even see the difference between a thoracotomy and a thoracoscopy type procedure. If you're having issues like that and you just really don't know and you're having a hard time understanding the training manual, reach out to one of us and we'll help you with that, especially sites who are struggling, who have failed this or did not meet expectations for this last audit. With that being said, I went through all of the audit results for all of the sites, and I looked at variables where there were system-wide issues. For example, there seemed to be consistency. There were a few sites who really struggled, and say those 6 sites who really struggled, they just, did poor on a large number of fields, where some of the other sites who had okay scores, average scores, they didn't have the same coding issues or abstraction issues. So, so that those are really site specific issues, right? When we look at that, and we want to work with those sites to help them. And if it's something that we're doing that could be done better for our side, on our side at STS, we want to know about that and make changes where we can. And then if it's something that the site is struggling with, a process issue, a resource issue, or even just a knowledge gap, we want to also help with that. So there's the site-specific issues, but then I looked at all the variables where we scored less than 95%, and I was really focused on identifying areas where we should educate on a national level, where we need to educate everybody on, because you could see it was scattered, the results were scattered, and even sites who did pretty well, maybe 95, 96, 97%. These sites were the sites where they were having issues, and these are the fields that they were having issues with. So it seemed to be more of a national base concern, where we need to educate everybody and focus our education for the webinars and for AQO on these fields. So what I found is that and we'll go more deep into the results of the field, but I just want to show you these 10 fields here are where it seemed that there was a larger number of people, and people who did really well in other areas of the database, where they got a few mismarked here in these fields. And diabetes control, we're going to go over these in more detail, where we look at the reason why. And then this is how Ruth and I, Leanne, and the task force will come up with training material to help. But diabetes control, preoperative chemo, preoperative immunotherapy, the FEV1 predicted, DLCO predicted ECOG score. Interestingly, the difference between a thoracotomy and a thoracoscopy came up quite a few times. Lung and esophageal cancer tumor staging, and then smoking cessation counseling. And the smoking cessation counseling is a little bit, we know that area is a little bit tricky. So we're really gonna help in the training manual come up with some very clear information for that, and give maybe some examples, like Ruth and I can work on that. This screen is pretty busy. I'm going to talk more about these post-operative complication fields, but these are the fields that were on the last slide. And I know it's hard to see, but like when we look at diabetes therapy and control, what I saw was that diabetes was being marked yes, but there was no documentation provided to the audit company that the patient was diabetic. And then the control was left blank or coded as none. And if the parent is coded incorrectly, any children that are coded after that are also going to be incorrect, no matter if the answer was true or not. So if you said diabetes therapy and then marked as yes, and then you said control marked as none or diet only, that's going to be a mismark on both of those fields because that patient did not have diabetes or it wasn't found in the information that was submitted to the abstractors. So preoperative chemo and immunotherapy, I couldn't find a trend here as to why we were a little bit low. 97.3% isn't bad, isn't a super low score, but what I'm concerned about is not when we look at the risk model variables and we looked at the endpoints, the different outcomes, pneumonia, ARDS, respiratory failure, et cetera. These are really, I look at these more from a site perspective and wanting to make sure that you don't miss out on coding a preoperative factor or a postoperative event or miscoding a postoperative event that could harm your sites when your data gets risk analyzed, when your data gets analyzed with the risk models with risk adjustment. So I really want to make sure that we're providing you good information so you can abstract these fields correctly and get the credit that you need for the procedures that your surgeons are performing. FEV1, it was a widespread issue. This only was at 80%. It was the lowest one. And what I saw here is many sites were not coding the highest value. So we'll focus education on that. DLCO, sites not coding the unadjusted value, but coding some other value that was found on the documentation. ECOG score, no ECOG score found in the chart, or there were times where ECOG scores were dictated by different people in their notes. None of the scores were the same, and the data manager picked a score that they thought was the correct score, and it's not what was listed in the training manual. It should have been the source document or the source documentation to be used for coding that field. All procedures performed, there was much confusion I saw around thoracoscopy versus thoracotomy and the coding of minimally invasive procedures. Some of these were very small denominators. So I think I saw some with like a 5 denominator, a 5 or a 7, which means if you only get 1 or 2 wrong, it's going to kind of screw up the outcome. So I didn't see anything that was super concerning here, just that we probably need to educate if we have questions to make sure we get good answers from the surgeons, and Ruth's doing a great job with working with the surgeons to do that. Smoking cessation counseling, this is a confusing field, especially if the patient was a former smoker in one section, but still requires smoking cessation counseling according to the definition of this. So we'll educate on that. And then when we get into the postoperative events, postoperative invasive procedure, pneumonia, ARDS, respiratory failure event, atrial arrhythmia, MI, delayed conduit emptying, and laryngeal nerve dysfunction or laryngeal nerve issues. There's a field that gets audited before this field. It's a parent field to the post-operative events. I think it's called complex or something like that, where you have to answer yes or no. And if you answer, if you answer yes, then all of these other fields open up and you have to select which complication the patient had. This is, what happens is if you answer that field incorrectly, if you say no, and that patient had any of the complications listed here, you get all of the complications wrong because you didn't provide an answer. STS surgeon leadership has been pretty strict on not changing this rule. We want to make sure that you're reviewing each of these complications. If the patient had any complications, that you're reviewing each of these complications to make sure it's being coded correctly for each of these fields. So please just be aware that pay extra attention when you get into the complication section, the postoperative section, that you're looking at all of the postoperative notes, you're looking at discharge summaries, anything that you have, even if it's, patient had an x-ray where you don't usually see a patient post-op having an x-ray and they go for a chest x-ray, pay attention to those kinds of things. It would be unusual for that patient or that patient population for whatever reason. This patient needed an x-ray and that x-ray might show something. So and then pay attention to the provider notes responding to those x-ray results to see what you need to be coding for these fields. So what I went through, so here is the The first number here is what our audit company said by using that rule that if the parent is marked incorrectly, then all of these fields are marked incorrectly. If we want, for purposes of audit, where we need to focus on education to make sure that these fields are abstracted correctly, if there's definitional issues, we need to know if sites are just not coding pneumonia correctly or not, which is different than saying that you miscoding a field. So I went through, and any where there were parent-child relationship, so this would have been 18 of 37 cases where the complications was marked no, but the patient had some type of complication. And so they got a mismatch on pneumonia. But this patient, 18 of these patients did not have pneumonia. There was no documentation of pneumonia. They were not marked off because they did not code pneumonia when they should have. So the true mismatch rate for this is about 96%. So you'll see ARDS was coded 100% accurately, respiratory failure. So you can see we did overall did fairly well, but just so you're aware, make sure that you're reviewing all of the complications. If you see anything that needs to be coded, capture it. One thing that we did have issue here was like the pneumonia and the respiratory failure, so we can work on, oh, I'm sorry, that was actually okay. Yeah, there wasn't anything here. Oopsie. MTDC stat, just one site had a one mismatch, so 99.8%, and then the 30-day status. We're going to talk a little bit about this, but what I saw is that sites did not provide a follow-up log to the audit company, so there was no other documentation that anybody checked their 30-day status provided to the audit company. Ruth and I will educate on log sites having tracking logs at their facility to capture both 30-day status and 30-day post-discharge any readmission. So there is information, should be in the training manual on this as well, but we'll educate and make sure that if you're audited that you submit these logs to the audit company so they have your tracking documents. So I'm going to go over, oh, wrong way. Okay, so what are our next steps? What are we going to do? How can we all work on this together? We should, first of all, we should say we did pretty good. We have audit results that are consistently good over the last couple of years, but there's always room for improvement. And how can we help you get there? And how can we work on it together? So we should provide more education on monthly webinars and at AQO. And I'm going to ask for our AQO planning calls that we include these elements in the presentations. Maybe we don't need to have a specific presentation about coding thoracotomy versus thoracoscopy, but maybe we need to incorporate that into one of the presentations so that we can provide some education that way as one of the takeaways from that. So we're going to focus on that, and we'll be planning AQO coming up here pretty soon. Sites to have someone familiar with the database to review documentation prior to sending it. A couple sites I had seen had a third party, either company or somebody outside of their abstraction or data management or quality area, send the documentation for them to the audit company without reviewing it. And as the auditor or as the abstractor, you are aware of where things are documented in the charts, and you are familiar with the 30-day documentation that needs to be sent for both post-discharge and post-procedure. You're familiar with all of that. You know where you primarily look for things. So it's super important that if you have a third-party audit company or somebody not familiar with the database pulling the documentation, that you review it or somebody who is familiar with it reviews it before sending, just to ensure that all of your information is sent and it's all complete. You don't want to get dinged for something that you worked really hard to do. So just keep that in mind. The other thing is confirm that tracking documentation is provided. So that would be your 30-day post-discharge and your 30-day mortality status documentation. Reach out to sites if complete documentation is provided. So this would be a note for the auditor that if a site provides everything except they don't see anything with their preoperative labs or their preoperative testing, PFTs, that the audit company acknowledges that and reaches out to the site who's being audited to say, hey, we didn't see anything in any of your records for PFTs. Did you send us that part of the file? So that's that's something that we can do differently. And then adjudicated results post-audit. CRS is the third-party audit company we use. They do have an adjudication process in place where sites have the opportunity to question their audit results before we send them out. It works really nicely, so we're going to continue to do that. And STS, either Leanne or myself, we try to be on these calls as much as possible, but we can't always join just because there's so many of them. But we do try, and then we're also available if you have a question regarding audit results. And then we're going to go into the 2022 audit. This year, we are going to audit, again, approximately 26 sites. We will be auditing 20 randomly selected medical records. It will be a mix of primary lung and a primary esophageal cancer cases. These cases will be performed between July 1st, 2020 and June 30th, 2021. Outside of the audit that was performed in 2021, we usually try to stick to a calendar year's worth of data. However, as you know, July 1st, 2021 was the go live date for 521. So we don't usually like to audit new versions if it occurs in the same calendar year as a previous version. We like to stick with that previous version just because sometimes there's some learning curves when we start abstracting for new versions. So we were going to audit just the first half of 2021, just January 1st to June 30th. But when we started talking more about it with the surgeons and internally, some sites may not have enough procedures within that 6-month time frame. So we wanted to give a 12-month time frame just to make sure we had enough cases to pull from. So we went with July 1st, 2020 to June 30th, 2021, and we will be auditing version 2.41. Sites will be notified May-ish. So expect to be notified if you are chosen for audit, if you're one of these 26 sites. I should mention we audit 10% of our sites for all of our registries. So this is about 10% of the general thoracic registry from earlier this year. So we'll audit this. That's how that number was decided. Those 26 sites will be notified in early May. However, we choose sites which are randomly selected. Sites are not, we don't usually pinpoint or we don't usually just say, oh, we want to audit you because we don't like you. We have a random poll process that occurs at IQVIA. IQVIA provides us with the list of sites. We make sure none of those sites were audited within the last 3 years, except in 2023. That will change. We'll be adding in sites who were audited 2 years prior that required re-audit because they did not meet expectations. But for 2022, we are pulling 26 new sites who have not been audited in the last 3 years. And then we're going to pull the associated data with those. And I'm going to go over the data fields and procedures in just a second. Once we have that pulled, we kind of do things over here. Emily does some magic over here to prepare notification and to check that we're not auditing the same person for multiple sites, because that's just kind of mean, and we want to try to avoid that this year. So doing all of that and all of those checks, sites will be notified May-ish sometime. This point is extremely important. If you are audited anytime you're audited, if you are audited, it's important to note that the data pull usually occurs in April. This year it will occur in April. Whatever's in the warehouse at the time of the audit pull is what is going to be used for the audit. So if you decide you want to update a whole bunch of data in May for sites, if you're chosen for audit and you freak out and you're like, oh my gosh, I got to make sure I'm correct and get all my updates in. Well, we assume that you have good data in the warehouse first, so that shouldn't even be a concern. We assume that your data is good and clean and appropriate for us to analyze. But if you freak out and you're like, oh my gosh, I got to get in there and clean up my data, and you decide you're going to clean up a bunch of cases that occurred in sometime between July 1st, 2020 and June 30th, 2021, in May of 2022, you should note that that data has already been pulled for audit. So what was ever in the warehouse, the time of the data pull, which will occur in April, that is what's going to be used for the audit. That is what they're going to be comparing what you have said versus what your medical records say. So just be aware of that. If you want to go in now, this week would be a good week to do it, just to check, but we don't know if you don't know if you're going to be audited or not. There's only 26 sites, so just hope that your data is all good to go and appropriate for analysis. So for procedures for 2020, we are only focusing on primary lung and primary esophageal cancer cases. And we here are the requirements for the esophageal cancer cases with the category of diseases that need to be coded along with the procedures. These slides will be posted, but they're the slides that we use for analysis when we identify primary esophageal cancer cases. But these slides will be posted if you want to refer back to them in a few days. They will be up there along with the recording. And then for lung cancer procedures, here's the category of disease, and then the procedures that will be. And you'll see that we have thoracoscopy in here. These are not just open, and they're not just not limited to lobectomies. We are looking at any primary lung cancer procedure, which could include a segmentectomy or a wedge, pneumonectomy, bilobectomy. So just be aware, we are looking at not just primary cancer lobectomy cases, but this is primary cancer lung resection cases. Here are the variables that we will audit. The ones in blue are new for this year. We added these in just to make sure we're looking at all of the risk model variables. Yeah, so these will be posted, and the audit list, the variable list, will be formally posted on the STS website, and I'll show you where to pull that down from, where to access it. I don't believe it's been updated yet for 2022, but it will be in the next week or so. And then now that's all I have. So I guess I'm going to hand it over to Joe.
Great. Thank you, Carol.
Thanks, Joe.
I don't have much today, just kind of a refresher of the items that were updated on March 26th, which is our most recent release. We did update the risk-adjusted dashboard report to reflect the lung cancer resection composite reports. So those are now available. And they will, the lung cancer resection reports will enable starting with the fall 2021 harvest results. Prior harvests will still display the lung cancer more and the lung cancer more detail reports. So anything prior to this most recent harvest will still reflect those reports. Anything from this report onward will be the lung cancer resection composite. And I think I have one more slide. Yep, just so other items for the risk-adjusted dashboard, the legacy report calculations were updated and are now displaying the expected results based on the PID data set. And then for the lobectomy STS and NIS compare reports, STS 6909, the minimally invasive lobectomy for clinical stage 1 lung cancer calculation was updated on the STS and NIS comparison report. And for the fall harvest 2021 NIS results were updated to use the 2019 NIS database results. And that's all I had. Usual reminders that if you want an update on anything that you've submitted, please reach out to our team and we can help you with that. And we will be posting additional items to the notifications section to let you know what's targeted for upcoming releases.
Great, thanks, Joe.
Thanks.
Now it's time for questions. And before we go over to questions, I just want to show a couple of things. Reach out to Leanne at ljones@sts.org for specific database questions. If you have operational questions, including who is listed and who is not listed on your site under the participants, reach out to stsdb@sts.org. Okay. And upcoming calls, April 27th at 2:30, May 25th at 2:30 for the 2 next user group calls. And then monthly webinars will be on May 11th and June 8th. All right, let me go over to, I just want to show where the audit information is posted. Didn't mean to go to YouTube, sorry about that. I'm screwing the whole thing up. 1 second.
You're doing great.
Are you laughing at me? Okay.
So many screens.
Clicking
I
on,
know, I feel your pain. I know it.
clicking on everything. Okay, so sts.org is your homepage. And then under registries, this first link is the STS National Database. This is the homepage for the database. So you'll find access to all of the 4 databases, and then access the databases IQVIA. Become a participant. This is where you'll find the participation fees, where your webinars are here. Recording of the webinars are accessed through this link. FAQ question box. And then if you scroll down, this is important resources. First is the database form. That's what I want to point out. That's your participant contact form. That's the link I posted in the chat box. And then down here is the audit. So this is where we have the national audit database audit policy listed here. So you could go ahead and read that if you are bored at night. And then if you want Emily, you could call her directly at 312-202-5839. She's sitting right behind me, so I hope she knows. She shouldn't post her phone number out there. Everybody's going to call her.
Oh my goodness.
All right. I get that. Okay, anyway, STS National Database, under General Thoracic Surgery Database, here's the instruction letters. Here's a sample of PDFs if you are chosen for audit. This is the sample PDF with bookmarks, and then information on the secure portal, Sierra's portal security. This instruction letter, it will be updated for the audits in this year's audits. It has not yet been updated. It will be updated or finalizing language. You could go ahead and read through this if you want, but if you're curious, when it is updated, you'll see the variables listed here. This is last year's variables. We added in more, but it will be provided here as well. So I just wanted to share that. Again, these slides will be posted with the information provided here for you. But if you have questions, feel free to reach out to Leanne, myself, or Ruth or Emily. All right, Leanne, I'm done.
Yeah, you did
I
great.
talk too much.
No, you did great. I'll read the questions so I can give you a break. All right, let's go ahead and tackle the questions. Our first question from Brooke. Is there any negative impact on analysis or harvest if a minor procedure is entered without a CPT code? Also, do you know of a resource available to look up CPT codes if we do not have access to the billing department?
Oh, I guess I don't know if
I don't know.
did you want to take that one?
I believe that the harvest question I can't particularly answer, but
yeah, there's no negative. Yeah, I'm sorry. There's no negative impact if a minor procedure is entered without a CPT code.
If you're looking for a CPT code and you don't have access to your billers, there are books that you can purchase. There's subscription services that are relatively inexpensive that allow you to look up CPT codes. That's what my institution moved to because they got tired of paying for books that we were throwing away every single year with updated CPT codes. And I mean, you can always just use Google as well. When people email me FAQs looking for a particular CPT code, generally I can find it using Google and then other resources if needed. There have been rare occasions where I can't find a CPT code for something minor. And it sort of just is the nature of the beast.
Thanks, Ruth. Our next question from Heidi. When can we expect for clients to have direct access to viewing their own current STS user contacts rather than email and STSDB? I don't know the latest update. I don't know if Carol or Addie have any information, but I do know we are in the process of incorporating the STS contact information database, our membership databases with the IQVIA platform. This is definitely no easy task, and it's taking a good amount of time, but we are in the process of merging those two together. So as soon as that process is finalized, then you all will be able to access your contact information via the IQVIA platform. But again, I don't know if Addie or Carol have any update on the status of that ongoing project.
I don't have anything to add other than that I know that they're working on it, and I don't believe that we have a go live date yet for it.
Right.
Addie, jump in if you have anything to add.
Yeah.
Well, that's great, Carol. Thanks.
Thank you.
Yep. Yeah, it's a very cumbersome, and it's taken a lot of effort and a very complicated process, but they are in the process and they're working on it. So hopefully it'll be live soon and we'll all be integrated soon. From Sarah, as an audit participant in this most recent audit, I must say my experience was much better than with previous audits. That's amazing. That's great to hear. Thank you for allowing us to provide feedback for the audit results prior to them being finalized. The communication with the audit company was excellent. So thank you, Sarah, for that feedback. That's very helpful, and that is great to hear. So hopefully gives those selected for audit this year, hopefully will relieve a little bit of anxiety for them once they are selected. Our next question, I see where you have ECOG listed. I have a physician that is not doing ECOG scores. He is my only GTSD doctor now. I thought ECOG was changing to not required. Is that incorrect?
It's not changing. I can take that one.
Okay.
What the problem is the in 521, we went back and forth with the surgeons on adding not available.
Mhm.
We're talking about ECOG.
Yes.
Went back and forth about adding a field for not available for the ECOG score. The surgeons were adamant that it should be dictated on every patient, so they didn't. Then we had more discussions, and they agreed that it's not dictated on every patient, but it was too late when we had that that decision. So the choice for NA got left off of this upgrade for the current version. So we're telling sites to leave it blank if you don't have it. We don't want you guessing or making an assumption about this. So leave it blank, and that's why we had to make it to allow the record into the warehouse. That's why we had to lower the other fields are marked. The other blue fields are marked as critical. So you would get critical errors if these other blue fields are missing. Right, Leanne?
Yes.
But we made ECOG score an error field, which is a little bit less severe of a warning to you. So we didn't block you from not getting it in because we're the ones who didn't add in the choice for NA. So speaking from a clinical standpoint, ECOG score is required. If you don't have it, leave it blank. In the next version, we will be adding a choice for NA, which would mean that if you did not fill in anything for ECOG score, the record will be rejected in the next version. We don't have a date yet, but for version 5.21, for this current version, just leave it blank. Your file will get in.
And follow up to that, Suzanne had asked if they leave it blank, are they dinged for that empty field on an audit?
If it's blank, it's blank. You're
right.
not, if it's blank, I mean, if it's blank correctly, then that's how it should be. What they don't want you to do, if you were to fill in 0 and you didn't have an ECOG score of 0 to support that it would be something that you would be marked as a mismatch on.
Okay, perfect. Thank you.
Can I add one more comment? Sure. So I think part of the confusion is what fields are audited and what fields are required, and it doesn't necessarily, like, it's not 100% match. So something can be audited that isn't something that goes into the analysis, although in most instances it matches pretty closely, if I'm recalling our meeting on the topic. And I think maybe that's what the data manager was getting at, is if this isn't a required field to get the case in, how can you audit it? And I think that because if you enter it, it goes into the analysis, it was the decision on keeping ECOG score as part of the audit process. If that makes sense. Is that the right way to say that, Carol?
Yeah, I think it makes sense to me. Mm-hmm. But I don't know that it matters if it makes sense to me or not. Hopefully it makes sense to everybody else. Yeah. I think you just explained it correctly.
Yeah. Okay, good. I hope that clears it up.
Yeah, great.
If not, just let us know.
Yeah.
Our next question from Heather, is there a way we could find out how many sites had a 3-star rating for all 3 composites? Yes, ma'am. The Harvest, and I don't know if Carol wants to pull it up since she's sharing, but within the IQVIA platform in the library, there is the fall 2021 Harvest Composite Quality Rating Summary document. So Carol's got it there. You can just download that, and there you have the breakout of the quality rating summaries for the lobectomy composite, the resection for lung cancer composite, and the esophagectomy composite.
Oh, I think, is she asking
It's which,
how many sites had
At all three.
star for
Yeah.
all three, what the overlap was?
I would have to get that. I don't have that information. But we would have to get that from DCRI.
Yeah, it's something we can ask for, see
Yep.
if they can easily provide it to us.
But we
Yeah.
can ask that. But in the
Okay.
meantime, we have the breakout here from this perspective.
I guess I'd be curious though. Well, I'll follow up. Never mind.
For all three. Gotcha, Heather.
Yeah.
Yep. Our next from Donna, my surgeon fills out the form and he marks the CPT and procedure codes. They are scanned into our system. Is this okay to use?
Oh. I wouldn't, I would still look at the procedures that were performed and make sure they align with the CPT codes he chose. Don't you agree, Ruth?
I agree.
Katie?
I mean,
Yeah.
the intent of the STS was always to use the operative report as the gold standard for what your procedures are that you're abstracting, and that billing data was not to be used as part of the as the only determinant on what was the procedure performed. You need to have the operative note support.
Yeah, and the consults.
Yeah.
Yeah.
So much of it is like intent, right? So if your surgeon intends to perform a lobectomy, for example, and the patient dies before the lobectomy gets completed, the training manual directs you to abstract the lobectomy as the procedure and collect the death. Your billing data isn't going to capture that because he didn't complete a lobectomy, I don't think, in most instances. So you have to be really careful.
Good feedback.
Next, let's see. Any suggestions if a site is chosen for audit during a time period where there was a system-wide EMR transition? In a case like that, medical record entries may not all be consistent and source documents are being updated.
Any
Thoughts?
feedback on that one, Emily?
I guess we would just, if you're selected for audit, we'll just need to have a discussion internally and get back to you. I don't have an answer at the moment.
Yeah, and I think sometimes Emily, and I think sometimes we could probably include the audit company as well. They might have some ideas.
Absolutely.
And I'm sorry, Donna had made a follow-up comment. She said her surgeon fills them out after he is done in regard to her previous question.
Correct. So I think that's still problematic because given the lobectomy example, you would capture the lobectomy even though it's not completed because the intent of the surgeon was to complete the lobectomy.
Yeah. Ruth, Donna is new to the general thoracic, her site's new to the general thoracic database. So I wonder if she should, and I think it might be helpful, maybe you all can connect outside of the call just to go through some of those types of questions.
Sure, of course, happy to.
Okay, thanks.
Yeah, Donna, if you want to email me directly, ljones@sts.org. If you want to email me and then I can set up a call if you would like to have a call with Ruth and myself, we're happy to do that and answer any questions for you. And Aaron, thank you for your question, Aaron. I got your email earlier, so I am, Aaron had a question about the inclusion exclusion criteria used for the minimally invasive calculation for the stage 1 section. So Aaron, I am reached out to our analysis analytics center, just getting a clarification from them. So once I have that response, I will follow up to your email and get those questions answered for you. So, and again, once I have additional clarification from the analytics center, I can get that information added to the overview as soon as I get clarification. So thank you for your patience, Aaron. And also I wanted to point out, Katie had put a comment in the chat regarding a good website for CPT codes. She said Craneware is a good site, a good website for codes. So I just wanted to note that. Our next question: what information do we need to have in our 30-day mortality log to substantiate that the patient is alive or dead?
Yeah, I'm gonna see if we posted something. I don't know if it's in 241. I think we may have posted it in 521 when at the beginning of the training manual as a suggestion, but let me see if it got pulled over. So there's instructions here in the first part. It says need to keep some type of log to include verification source, date assessed, status of mortality, and readmission. It can be done in a simple Excel spreadsheet or a document attached to the DCF. Name, surgery date, discharge date, the day you checked for the 30-day status of the patient, so 30 days post-op, and then the 30-day post-discharge readmission status. And you also want to check for infections and if that patient was readmitted. So just a simple Excel spreadsheet is what most sites who do this is what they use. So we were also asked on the adult webinar about if you could use the notes within your vendor software, and you certainly can do that. Just make sure that if you're audited, that you pull those notes and submit them with your audit. Your notes that you put into the vendor software, they do not get updated or uploaded to IQVIA. So we don't have those to share with the audit company when we pull your data from the warehouse. So you have to provide those separately. The tracking spreadsheet's nice because if you're able to do that, that's usually what's easiest for the audit to make sure everything is there for a certain time frame for your patient. So.
Thanks, Carol. Our next question, you may have already mentioned this, and if so, I apologize. When do you expect the next new version to go into effect?
Sure. So usually we do version upgrades every 3 years. So the next version upgrade for general thoracic would have been 2024. We would have started that process this summer in 2022. However, STS surgeon leadership felt that the last general thoracic upgrade for 521 was very successful, made a lot of wonderful improvements in both the data abstraction process and in the relativeness. I don't even know if that's a word or if I'm making stuff up, but how the data has evolved to reflect the current practices in general thoracic and esophageal surgery. So at this time, we are not doing an upgrade. We do not have an upgrade planned for general thoracic. We're going to stick with 521 at least for a few more years. I hope that helps.
Yes.
Okay. Very wordy answer. Sorry.
Okay. I don't know if Jan meant to put that in. She was audited last. I don't know if you could clarify, or I don't know if you're just trying to get a partial question in. Let's see here. All right, it's 2:30 Eastern time. I don't see any additional questions coming in. In the meantime, while we kill a couple of minutes, our next webinars are scheduled. Our next user group call is scheduled for the 27th of April at 2:30 Eastern. And our May user group call is May 25th at 2:30 Central. Next monthly webinar is May 11th at 1:30 Central and June 8th, 1:30 Central. Still don't see any additional questions coming in. Going once, going twice.
I got a fun song for our departure.
You have a good one? What you got for us?
Oh, it's 80s hair band. Yeah.
Oh, hold on. Jan's got her hair. You said hair, and now I said Jan has her hair raised.
Okay.
Let me see. Jan, do you have a question? I unmuted you. Yes, ma'am.
Okay, I started typing, but it's really long. So
that's okay. Yeah.
I was audited last year, and the way I sent in proof of like 30-day status is I actually would pull like a lab result or a physician office visit, and I attach that to the file. Is that okay, or do we still need to make do the log?
Yeah, I mean, it's okay, but if it's okay to do that, Jan, but if you have a patient who is not like a community level patient, maybe somebody from outside the community who might be following up at another facility that you don't have a connection to within your EHR, that's where it gets a little tricky. So you would want to make sure that you have some type of even if it's a document that says so-and-so patient surgery performed on this day,
Mhm.
verified patient was alive this day, but you need to still provide us that the patient wasn't readmitted somehow, and that the patient didn't have an infection. So
Yeah, and
they have,
that's really difficult because we are a regional
yeah,
facility in Nashville, and pretty much 80% of our patients come from someplace else.
yeah, that's why it's tricky. So it's easy for you to verify 30-day status because your patients are probably connected to a system.
Yes.
But for the mortality and the 30-day post-discharge readmission, that's where they could go to any hospital and get readmitted. You might not ever know. So just having some form of communication with the physician's office, the performing surgeon's office, they usually know if those patients are readmitted within 30 days, working with their either administrative or
Or their
their,
PCP.
yeah, or the PCP would work as well. Usually the surgeons are pretty aware of their patients,
Yeah.
at least for that 30-day mark. So Jed, just keeping a formal log like that for those two fields, the readmission and the readmission and the infection, I think would be helpful. But you might as well just include the 30-day status and just say lab found on this day, just so you have one document you can refer to for all your patients. And then it also helps that you could just sort that document and see who you're missing 30-day status on before the harvest close, and just try to fill it out like that. I guess I've done that, but not at a very large hospital like yours. So
Yeah, because I cover 3 facilities.
yeah.
Yeah.
I think this is Ruth. I think.
Okay, thanks.
Can you hear me?
Yes,
Yep.
ma'am.
Yeah, Ruth.
So I think it's worth it to have a conversation with your surgeons' offices at the facilities in cases where my patients aren't, or our patients aren't seen at 4 weeks to get that 30-day status. The office actually calls the patients to update, were they readmitted elsewhere and did they have any post-operative events? And they put that note in Epic where I can see it, because we know we can't make that assumption. And I'm one person and they have a whole staff. So it's more, the surgeons know that they need this data. And so their offices should be able to work with you. Hopefully it's worth the conversation anyways.
Ruth.
Yeah.
And thanks, Jan and Carol. All right. Okay. I don't see any additional questions coming in, but thank you all so much for joining today's webinar. It was a great call. Great presentation, Carol, on the audit. Amazing job as always. So with that, thanks everybody for joining. If you have any questions that come up after the call today, please feel free to reach out to myself, ljones@sts.org. Happy to get your questions answered. And Erin, again, I'll be following up with you on your question related to that minimally invasive section. So I am working on that for you. So with that, thank you, Ruth and Carol and Katie and Emily, Addie, everyone, IQVIA team. Joe, thank you all for joining today. So I like it, Carol. I like it. I like it.
Bye, everybody.
So thanks, everybody. Have a great weekend. Have a great rest of the week.